In the event that the patient presents with a pain in extension, a hypermobility at L4, L5, and a hypomobility at the adjacent segment of L3, L4, we will need to treat the L3, L4 segment with first local traction, followed by joint-specific extension gliding at that segment. Let's first do L3, L4 traction. In order to perform the traction, we first need to preposition the segments around L3, L4 to reduce the chances of the technique being painful. Now, in order to produce a traction mobilization at L3, L4, we're going to want to separate the L3 inferior articular process from the L4 superior articular process in a direction that's perpendicular to the orientation of the joint surfaces. To do that, we're going to use right rotation in this case. By right rotating the patient and allowing the segment to side bend, it's going to separate those two segments sufficiently to create local traction. So first, we want to preposition the pain-generating segments and those segments below. We will use flexion in those segments because extension is painful. Ultimately, we're going to rotate all of the segments to the right. L4-5 and L5-S1 will rotate to the right. L3-4, the segment that we're treating, will rotate to the right. And L2-3 and above will also rotate to the right. Because we're going to flex L4-5 and L5-S1, the segments above that segment we should allow to extend, and they will extend in response to the rotation that we produce in the spine. In the L4-5 and L5-S1 segments, if flexed and rotated to the right, we want a left side bending to allow us to lock those segments. In the segments above, we need to first lock L2-3 and above so that we can focus our traction mobilization on L3, L4. So in an extended position with right rotation, we will want to put in a right side bending. And finally, when we rotate L3-4 to the right in an extended position, we will allow it to side bend in the direction that it naturally courses, because we're not sure how the L3-4 segment is going to couple.